to another edition of the Cutting Edge interviews. I'm absolutely thrilled that alongside my co-host, Professor Venkatesh Munikrishnan, we have one of the world's most foremost innovators, I suppose cutting edge surgeon, researchers, and editor of the recent digital surgery book, Sam Atallah. So welcome, Sam.
Thank you for having me, Manish. Venky, it's a pleasure to be with you guys. And I hope we can keep this as a casual fireside chat. I've got my fireplace going, you can see that. And this is just a conversation among colleagues, hopefully looking at what is next around the corner and what are the next steps and frontiers in surgery.
So Sam's been a champion of anything which is in the cutting edge, so it is only right that we introduce you to our program early on, because, be it transanal surgery or, your book digital surgery, using technology, to drive collaboration, research, and surgery. I think you've done it all. So we would like to hear from you. What if someone wants to start off in the space? What do they need to do right to get onto this ladder?
Amazing, exciting new frontiers. Certainly get interested in them, but earn a strong foundation by doing many clinical cases, surgical cases, honing your surgical acumen and your research acumen. Right now, I think many great areas that are going to probably revolutionize surgery and what we're doing today that will happen over the next 5 to 10 years. And one of them is broadly thought of as nonlinear robotics. So let's just take a step back and see where we've come. Where is robotics and how has it evolved? Essentially, over the 2000s, from 2010 to now even, we've really looked at robotics as an alternative to laparoscopy. And we have many comparative studies that say, how does lap fare compared to robot? And robot versus lap versus open. And we haven't, in our minds, tried to say, how can we use robots in ways that we can't do this operation laparoscopy? The approach that we're going to, are we in now? So the approach is that the innovators, I guess the leaders who are looking at what we can do next in robotics, are excited about the possibility of using robots in ways that we're not able to. We're not able to do this with an open technique. We're not able to do it with laparoscopy. We don't want to just simply butt laparoscopy and go head to head with robot anymore. We want to see what we can really do with this robotic technology. And let's face it, what is robotic surgery today? We don't have robotic surgery. We have telemanipulation. So it's much more analogous to how a jet pilot steers an aircraft by fly-by-wire technique. That's the robots that we have. We have a control, we use it, it's a telemanipulation, albeit extremely precise. It's telemanipulation just like a jet pilot flies a jet fly-by-wire technology. And we need to also explore how we can use robots to get to anatomic targets that are heretofore not possible with laparoscopy. And so what does this mean? This means let's target anatomy that is curvilinear, okay? The foregut, the throat, the back of the throat, the anorectum, the entire GI tract. Anything that does not follow a linear path requires a device or instrumentation that is curvilinear, okay? This has recently been shown to be quite feasible with navigated bronchoscopy to reach targets that are not definable, not reachable with conventional straight robotic, linear robotics. And so that's the next step forward. In our so-called space, Venky and Manish, the challenge now is how can we do the great innovative things like TEM and TAMIS at a much higher reach within the colorectum? Well, we have to follow the path of a circuitous anatomy. We can't do that with a linear straight stick. We've done wonderfully with TAM. We've done wonderfully with TAMIS. I'm very proud of TAMIS. It has really stood the test of time. But how can we now apply this to much higher areas? And that's the idea of nonlinear robotics. Today, what do we do for that? Well, as surgeons, we do very little of this, and most of it is done by our GI colleagues, and that's EMR and ESD. And what are they using for that? They're using an antiquated technology. You know, the flexible fiber optic scope is antiquated. It's been around since the 1950s, and it has not evolved dramatically. So
what does that look like in terms of technology to get around those engineering challenges? Are we talking about smart fluids? Are we talking about magnets? Are we talking about what kind of technology are we going to use to navigate around that circuitous anatomy?
Right. It'll take more than probably one kind of technology, as you have actually just brought to my attention, Manish, the new approaches being considered for colonoscopy where they're magnetically driven. But right now, and the ideas that we're exploring is mainly interventional procedures done with a colonoscope, is that everything is done on a zero axis. So my instruments come in directly at my camera. As we know from our background, the first thing we do when we set up a case is we triangulate. And doing this requires instruments that are flexible and ideally robotic. That is a tremendously complex engineering challenge to develop. And it's not an accident that it's taken 20 years to develop endoluminal robotics. And finally, I believe we're there. And, you know, without specifying any one company or manufacturer, I think that we will have vendors come along who have solved these important engineering problems to allow us to work and operate within the lumen using nonlinear robotics, non-straight devices.
Robotics, endoluminal, I think it's an exciting area because, you know, we're trying to be minimally invasive. And I think that's truly minimally invasive because rather than going transabdominally, endoluminal surgery has got a huge scope because it's a natural progression of, you know, pushing the envelope. So tell me about the recent video which you posted of the use of endoluminal robotics to what you did.
Perfect. So this is a new kind of platform. It's a non-linear robotic platform that allows one to navigate and work up to 60 centimeters from the anal verge. Wow. And eventually the hope is all the way to the cecum. So where are we limited to now? With TAM and TAMIS, it's approximately, give or take a centimeter, 15 centimeters. That is the rectum proper. We want to take that technology and move it forward and do the sorts of things that we can do with TAMIS and TEM today. Tomorrow, do that in the sigmoid, in the descending colon, in the transverse colon. That is the future. So the video that I posted, that was a cadaveric dissection using a nonlinear platform. In the United States, we have started a FDA IDE approved trial looking at a clinical trial looking at the feasibility of using this device with certain parameters and restrictions. Although it can now go to 60 centimeters, we're only investigating the feasibility and safety to 12 centimeters due to a sort of an initial phase of the study that will eventually look at using this technology to resect lesions that are higher up. So how does this exactly work? So I mentioned that the most fundamental aspect of endoluminal robotics that needs to happen is the ability to triangulate. And this system does that. It allows you to, Venky, just like you use scissor tips when you do your robotic abdominal surgery, I can do that here as well. Wow. We generally don't use scissor tips in transanal surgery with straight stick laparoscopic techniques for TAMIS. because it tends not to work as well as something more fundamental like a hook cautery. But here we're able to do that. And we have that precision that you get with robotics abdominally, only we're operating within the lumen in a very fine field. But there's a couple other important aspects that this platform allows us to do. And one is to variably control not only the position of the entire platform, so I can move the entire platform up, down, left, right, or I can leave the platform put where it is, and then I can just move the camera forward, backwards, and allows me a much more controlled environment. If I could sum up everything about digital surgery, endoluminal surgery, you name it, it's about obtaining control over the operative field. I think that's what we need.
I suppose it's interchangeable with the term precision surgery, which often some people use as well. And if you've summed it all up so succinctly with that phrase, let's talk about digital surgery, the book. I mean, a fantastic book, fantastic concept. And I know it's been years in the making, and I think we're delighted to be part of that book as well. You really got a truly multidisciplinary, international, multi-faculty of writers. And you know, how did that come about? Why did you decide to go with this book? And how did you sell it to the producers?
First of all, I want to say thank you for being a part of it. That was amazing that you were able to contribute so wonderfully. And I want to say that it really, how did it come? There's many questions, and let's break that apart. First of all, when I pitched it to Springer Nature, within 24 hours, they responded and said, yes, this is a good project, let's do it. And it grew from being originally just 14 or 15 chapters, as I outlined to them, to 30, because digital surgery is multifaceted and it encompasses so much, and is really the application of all sorts of technology towards advancing surgery. And it has many different levels, but one of which is how to take information that we're already, you know, have helped us to understand anatomy preoperatively. Manish, like you have worked on in the Mercury study with Gina Brown, you know, that gave us such an amazing ability to use MRI for the rectum and rectal cancer as a roadmap for our surgeries. The next step, and a big part of digital surgery, is to be able to use that and apply that intraoperatively, whether it be with augmented reality or navigated surgery. Those are the important next steps. We already have very great ways to image tumors, to understand them, understand their proximity in relationship to important vessels and other structures. But what we don't have is the ability to live interpret that during surgery. And that's the next step that we want. So a big part of digital surgery is about that. But again, it's multifaceted. It's about using sophisticated models and simulators to be able to, for example, do your surgery beforehand, or to study and learn the complexities of and the nuances of doing some kinds of operations that require and mandate a high level of understanding. It's also about using targeted dyes. So ICG, we're all gaga about ICG. We use it for assessing perfusion and things like that. We're fantastic about that. We've written tons of papers about it. But what about targeted fluoro dyes? All right. I think that is something that's very exciting. It will happen by conjugating ICG, for example, to specific antibodies or markers for a tumor. We'd be able to target them. And if we can get it done right, and if we can have it done with the appropriate sensitivity and specificity, I think it will really change how we do surgery.
I mean, I absolutely love the concept. I mean, it is just focusing down on what we need to do with a target, with the engineering to get there so that we have minimal morbidity. I mean, there are very few situations in healthcare and surgery in particular where we go bigger. So if you think of, we all know the principles of oncology from decades, but actually we just get more and more precise. And I think a combination of endoluminal robotics, a combination of targeted smart fluorophores, image-guided surgery, true image-guided surgery within the operating room. I mean, these are the things that we're going to see over the next decade. And I think it's going to be an exciting time. And I'm sure we can read a lot about what may sound like science fiction, but I actually think it's the reality when we come to it, and it's all in the book. So I would highly recommend it for those that haven't got a copy of it yet.
Humanities.
Sam, I was going to ask you, one of the challenges we face in at least locally, in a big country like India, is where, or even the US, it's a big country, the talent or the resource surgeon, which could be you or Manish, are located in one place and your target patient is in another place. Now, we've discussed robotics, you're the master of digital surgery. It's a natural fit, won't it? If we can do this on the cloud, the connection between the surgeon and the target, maybe in the Himalayas, you sitting in, wherever you are, Florida, New York, Washington, whatever it may be, that wire connection is gone and we are on 6G, 7G, and you can telemanipulate and deliver high quality surgery. Do you think that's coming?
Venky, you are 110% correct. This is coming. This is exactly part of the future. Maybe not 3 or 5 years even from now, but eventually will be. It's hard for us to think about surgery 100 years from now or even 50 years from now, but many of us feel this is going to be a part of it. And let's take a step back and look at how we have evolved surgically. So it used to be open surgery. Let's just take a step back and paint with broad strokes to understand. It was a surgeon directly at the bedside, directly manipulating an organ, right? Then we moved to laparoscopy, where the surgeon was still at the bedside, but could now remove an entire colon, think about it, without ever touching the organ. So that's a huge step forward. But the surgeon was still at the bedside. Then we got to robotic, quote unquote, robotic or telemanipulation surgery, where now, and I'll tell you, right down the street from me is a very busy prosthetic surgeon, Dr. Vip Patel, who's world famous. Yes. And I can tell you that he has a multitude of folks working with him, and he basically does the surgery without ever having to walk into the operating room. And I'm not exaggerating when I say that. His console is outside of the operating room. His fellow or assistant is in the operating room, places trocars, etc. And he is a telesurgeon. Venky, of course, he could be in India right now doing that. We know we have the technology for this. He could be anywhere in the world, and the patient could be anywhere in the world. Yeah. And so all of these platforms that we've seen, the video I posted, all of the future of robotics and surgery, moves the surgeon away from the patient, connected by wires or wireless, doesn't matter, now creates this remote environment. And the cloud is going to have a phenomenally large role in the development of robotics itself in the future as well. Why is this? So if I take my computer, the one I'm talking to you with now, all of the memory and its brain is here. Well, this raises the cost and it limits how much I can put in my light laptop, okay? But what if I can take all that computational power and throw it up in the cloud and have sort of like a dummy computer here? Well, that offloads all of the work that my computer has to do and puts it on something else. Yeah. And that has a huge future as we meld together these other things coming online pretty quickly, such as computer vision, most importantly, and artificial intelligence, the ability for a robot of the future to really discern and think and help a surgeon in a way as a senior colleague could help a surgeon, a junior colleague through a case. Those are all things that are coming that are based on the advancements in the cloud and how it can be used to power robots. The book, Digital Surgery, has an entire chapter dedicated to using the cloud for robotics and surgery, by the way.
Great.
Well, Sam, look, I mean, I think it's absolutely fascinating. And I to move on to our last segment in this interview, and I could literally sit here and listen to you all day talking so passionately about the future of surgery. But I suppose these platforms and social media platforms have led to an increase in the amount of collaboration we had. I know that we met several years ago now, discussing some at the time it almost seems archaic data, but things have really moved on, and we've begun to be able to share experiences, share expertise. I mean, what are your thoughts on how that side of technology has advanced research, teaching, clinical practice, patient outcomes?
And I were talking offline before this segment. Now in the era of COVID, more than ever, we need to connect in this way. We need to share ideas in this way. I mean, I post a video, a brief 50-second video, and it's gone around the world 100 times by the next morning, and allows people in all countries who have access to social media to see and view and see what is going on. What are, tell me something in the moment, and instantly we can share those ideas and be so much more enlightened than we were if we weren't, So I think, it's an important way, we all have a group of surgeons, for example, that we follow. And we pick folks that we think are going to present and show us things that are up and coming, and sort of tell me something new, show me a great new paper, excite me, enlighten me, and those sorts of things. So Twitter is my favorite platform to use, but there are others that are very popular and I think work very well. The Facebook closed groups, YouTube videos are a fantastic way to sort of take especially folks learning procedures and take them through a case so that they become more familiar with the anatomy and the technology and things of this nature. And of course, our journals now using this more than ever: Colorectal Diseases, DCR Journal, Techniques in Coloproctology, all using video as a platform as well. And they're all using social media to share exciting content with folks all around the world.
Thank you, Sam. Thanks for sparing your time and sharing your immense knowledge in this field. I mean, the future looks bright and exciting, and we can't be part of it. But as change agents, we have to keep pushing the boundaries, because we are the guys, led by someone like you, to show the future and show the junior surgeons who are just evolving that this is an exciting field to be, and 10 times more exciting than we were training. So thanks for your time, and we're going to put the links to your book in at the bottom so that people can follow that. So see you soon, hopefully in person, and take care.
Okay, take care. Thank you. It's been a pleasure.
Catch up on the next show.